Hello, everyone. Welcome back to my series on mental health issues. Um, so, first off, I want to address I have a new camera. Hopefully, that makes things a little bit easier to not only see me, but also makes it a little less janky for you guys and a little easier for you guys to focus. Um, to start off with, this particular topic is going to be incredibly broad because we're going to be talking about the problems within the mental health care system, especially in America. Keep in mind that most of this is going to be related to what happens in Texas because all of my experience with mental health has been within Texas and has been for the past 5 or 6 years or so. Um, Keep in mind that I'm going to be trying to do this in broad strokes, but giving as much detail as possible and including anecdotal evidence, both things that I've experienced from the health practitioner side and things that other people have experienced from the client side of things. Now, this is such a wide topic, but I want to start off with the problems that we see for people who are unfunded and who have no money. So, I have always been a proponent that everyone should have availability to healthcare. I've always been a proponent that healthcare should be free. Mental health care is mental health care should be with that. Absolutely. But the problem is that mental health care is treated as if it's a secondary class thing. Either you have the money to support yourself to go to therapy and do all that, or if you don't, the only thing that you really have is psychiatry, which is medications to help you cope with the symptoms of your illness, whether it's Seroquel to help you sleep, whether it's fluoxetine to help your depression. And there are hundreds of thousands of different medicines out there. Each do something kind of different for individuals. So, no two brains are going to be exactly the same. No two bodies are going to be exactly the same. There's going to be variations. And a lot of times, what ends up happening is medications don't feel like they work for people, which is more to do with us not educating enough when it comes to psychiatric care. Now, I'll go deeper into that topic a little bit later, but I want to start off with how one of the biggest barriers for people who don't have insurance is if you don't know where to start. A lot of them end up doing what a lot of my patients and clients that I've been seeing recently do now, which is if they're feeling desperate, if they feel like everything is just too much and overwhelmed, they're feeling suicidal, or they're feeling homicidal, they come to the ER. When they get to the ER, they don't know what to expect. But taking, for example, in the Dallas Metroplex, most hospitals within the Dallas Metroplex do not have psychiatric care units. So you don't get moved to a different psychiatric unit. You get to stay inside the ER until we can place you at a completely different facility that specifically does psychiatric care. And that wait can depend on whether you're insured and how busy things are. There's a lot of issues with that structure in general, but for a lot of people who feel at their wits' end, this is their first course of action. Okay, things are so bad, I don't know where to start. Let's go to the hospital. Understandable that that would be where they start. And the frustration that comes with if you're not insured, we have to go through community mental health to try and get you coverage. And that can look wildly different. And I'll talk about community mental health, where that started, the history of it, and the problems with it, because that's also deeply interconnected with what we're talking about today. Moving forward, though, many of the people who come in who are unhoused, who are just poor, who have very limited resources to begin with, suffer from having to compete almost with everyone else for resources. That's because mental health in America is the opposite of a capitalist wet dream. It is a dry, barren field for them. It is a constant burning of your money to them. And so, since it's not lucrative, they don't want to put more money into mental health. In fact, if they could, they would get rid of it all entirely and just let people die, if it saved them a few quarters. But that is a function of capitalism being part of the problem. There are other problems involved, including elitism and imperialism, that we've talked about a little bit briefly in the introduction. So, when you don't have insurance, what do you do? What is the what is the best option? Well, let's say you go to your local community mental health. In Dallas, that would be Metro Care Services, Child and Family Guidance, or something along those lines. The problem is that these places, community mental health, are almost constantly overwhelmed with people. So, in the Dallas area, there are about 4 or 5 community mental health places for you guys to go to. Using that as an example, we are a huge metroplex consisting of individual counties that are basically lumped together. Most places don't even have that. So if you live out all the way in what some might consider the boonies, where there is no mental health care, it kind of just up shit's creek. And that's another common problem, is that community mental health requires community, it requires a lot of connection. But when you are one of thousands of people who have to be seen in a week, it feels terrible. You see a psychiatrist, and that psychiatrist essentially has to see you on top of however many hundred people in that week that they can. You get 15 minutes with them. If you're brand new, you get an hour. And then, after that, it's 15 minutes, and then they're back to the meat grinder with the next person and the next person. And a lot of that burnout comes from there are too few practitioners and too many people that need to be seen. And what inevitably happens is people don't feel heard. They feel ignored. They feel like, hey, I keep telling you this medicine makes me feel weird. Just keep taking it. Just keep taking it. Even though you should have far more say about what happens with your medication. Now, if you have no insurance, you have to get coverage through some means, which in Dallas, we use the North Texas Behavioral Authority. NIPTA is a name that you will hear me say very often and with a lot of contempt. And that's because the number of people who get coverage through them is both extraordinary and also very frustratingly few. What I mean to say is, so going back to people in crisis who come to the ER with suicidal ideation, they've got a plan, they've got a method, they know what they're going to do, right? The big three determine how much of a crisis you're in. And let's say, for example, we say that person needs to go inpatient, but they have no insurance. So what do? We have to go to NIPTA and say, hey, these are the facts, this is what's going on, this person needs to go inpatient, that is our recommendation for their level of care. They then have to wait for NIPTA to give approval. And NIPTA can decide at any point, but they came to the hospital looking for help, so they can't be that suicidal, right? Just send them home. And yet, whenever someone is at risk to possibly harm themselves, and this is just one example, by the way, it's the most common example. Whenever someone's at risk of harming themselves, inevitably that person typically goes through because our offices have to fight hand, claw, tooth, and nail to say this person is an imminent threat to themselves. If we do not intercede or if we do not intervene, something terrible is going to happen. Meanwhile, that person is waiting in an ER room with, if they're lucky, a TV and a bed, and that's it. Because they don't want anything in that room that that person can turn to harm themselves with. It's a miserable experience in just a dank room that's just dim and like most people don't enjoy it. So you're sitting in that room for up to 3 days trying to determine if you're going to go anywhere. And in that 3 days, if you have other like comorbidities like ADHD or most commonly substance abuse, you start to get antsy and you don't want to be there anymore. Gee, I wonder why, right? So what ends up happening is a lot of times people will just leave. If not, they're told they have to leave because after 3 days, NIPTA gives us an answer of, we're not going to cover this. There's a lot of back and forth, and there have been people who wait up to 2 weeks in those rooms, not being admitted to the hospital proper, waiting for someone to give approval, if they ever do, for their mental health issues. It is a nightmare. These sorts of issues create revolving doors where people get let out, come back because, of course, they're still suicidal, or of course, they're still feeling terrible and they don't want to die. They don't want to end it. And so they have to keep coming back. The other major issue is that psychiatric hospitals in Texas and generally in America, as far as I'm aware, are not long term. Going to a psychiatric hospital typically for most people is anywhere from like 2 to 3 days. They get you stabilized, they give you medicine, they kick you out. Now, for some people, depending on the behavioral issues, if there are any behavioral issues or like risky behaviors, they can be there for 2 or 3 months at a time. Very rarely is it longer than that. And you'll hear stories of people who have been in there for 6 months. Those are exceptional, like rare cases. They're not usually, because the whole point of a psychiatric hospital is to get you stabilized and kick you out as quickly as they can so that you can deal with this on your own and not be their problem. That is how the whole of the system treats the individual. They want you to seek treatment on your own, do this on your own so that they don't have to be, so they can get to the next patient, so they can stabilize that patient, go to the next one, etc., etc. It is, again, much like community mental health, it is a meat grinder. And because the spaces that we have are limited, meaning that they don't have endless rooms, we don't have the asylums and institutes that we used to. So that long-term care is completely missing. It's all put on the individual. The major issue with that is that when we got rid of institutions and asylums in favor of community mental health, what we essentially did was we took people who almost could not live on their own, who could not function on their own, or had major issues. And I'm not saying that everyone's going to have this, but I'm talking patients who have extreme schizophrenia, who have extreme bipolar disorder where they can't hold down jobs, they can't take care of themselves most of the time. Again, these are rarer, and in most cases these are on the more extreme side of things. But what ends up happening is they end up going to group homes, or they end up going to um, again, the revolving door of rehab and all kinds of things where they are constantly having to get their medications adjusted and feel like nothing is working for them. And sometimes they can't even like function enough to tell somebody, hey, this isn't working. Now, to address the problem with asylums and institutes at the time, they were terrible. They were abattoirs of just putting people all together in a room and letting God sort them out. Terrible fucking function. Absolutely. But when you have no structure in place to replace that, and you put it all on community mental health, which is basically saying, hey, you guys know what you're doing, right? Just take care of these assholes for us. The general populace has no idea how to deal with people with mental health issues. That's why they bring their family and friends in when they have a mental health crisis, because it is so far out of their depth. And we can no longer claim, like we did in the wild west of mental health, where we didn't know how to treat these things. So we used all kinds of experimental shit, including the lobotomy. But now, we don't have that. We know how to treat these things. We have seen people who constantly come in because they can't care for themselves in a way that can stabilize them. And if they had the shelter, if they had a place where they didn't have to worry about surviving in the environment against the elements on top of the human element that abuses them, they would have an easier time being able to find the wellness that they need. But that is such a hard thing to provide people, because again, there are so many people in the community who need that help, and so it becomes that we have to get to the next patient. We have to get to the next patient as quickly as possible. And the system becomes overburdened. And so, again, a psychiatric stay is usually 3 to 9 days, especially now if you have insurance. If you have insurance, it can be up to 9 days. You have what's called psychiatric days. And if you use too many of them at one time, you'll be denied going back to an institute. If you come out and say, I'm still having suicidal ideation, don't let me go. We can't hold you. Your insurance won't let you stay here. We have to let you go. So you come back to the hospital. I'm still suicidal. I've got my plan. I've got my action, etc. What ends up happening is you may still get denied if you're out of psych days, in which case you are told you have to follow up with outpatient care. There are, and we'll talk about that a little later, the different levels of care, but I'm going to be focusing more on psychiatric crises for this episode. And that's someone who needs inpatient care and then has to wait. All of the things that are connected with that as well, though, there are a limited number of shelters. In DFW, the number of homeless shelters, let's see, I can count on one hand: The Bridge, Dallas Life Foundation, Salvation Army. Yeah. Technically, there are transitional living places for families, like the Family Place, but there are not that many shelters. And that's just for DFW. Homeless shelters are kind of hard to find because, as you can imagine, nobody wants to put funding into it because for them it's a money hole, it's a money sink. And on one hand, I get that, but at the same time, why should it be? This goes back to, there are homes out there that have been bought out by corporations and companies to rent to you guys and make Airbnbs at exuberant prices that we could have easily just bought out some of these places and given them to people. But no one wants to do that because who wants to give these people handouts? They're suffering. As it is so difficult for many of these people to even get on disability. That is going to be a separate episode. Getting on disability, the hardships of that, that's going to be a separate issue. That's going to be a completely separate video. I've got plenty of thoughts on that. But moving forward, when you have underfunded populations who constantly have to come in because they're not, again, they've got no permanent shelter. And they come because the shelters get full up quick, and a lot of the shelters have very stringent rules. And many of these people are fearful and paranoid about the people around them because they've had experience where they've been robbed, they've been hurt by other homeless people. And not just by other homeless people, but by other people in general. Again, the unhoused get typically very, very abused if they don't get left alone. And so that constant instability in their lives creates worsening conditions for their mental health, as you might imagine. But by the time they come back for the fourth or fifth time, the doctors are burnt out seeing them. The nurses are burnt out seeing them. Most of the patients are usually kind, but at that point, you start to feel the burnout from the doctors and the nurse practitioners and all of that, that they're just like, well, they're not engaging in their own mental health care, which can be true. And what ends up happening is that same said person will be called a malingerer, meaning they keep coming to the hospital looking for treatment instead of going to the community mental health centers, looking for treatment there. And there's this concept of, okay, this person is homeless. Where do they stay? Like, is there an area that they stay? Typically, they're constantly having to be on the move. Why? Because having any encampments means that if they try to build community, eventually what will happen is the cops will come down, destroy everything, and kick everyone out. Because cops are only there at that point to protect private property. And if the rich elite people who see the homeless feel bad about it, they suddenly don't want to see that anymore, and they want them pushed out so that they no longer have to see the smelly people who need the assistance, who need the help. Very common thing that happens. And so they're constantly nomadic throughout the city. I've known people who go from South Dallas, East Dallas, North Dallas, West Dallas, and back because they have no other recourse. And oftentimes, what will happen is you'll get people who, again, because they're constantly being on the move, they're not always close to those community mental health areas. Imagine you have to walk everywhere because you can't even afford the bus, and being told, hey, you need to go to this location, which is however many miles from where you are right now. You're going to have to walk there for your appointment because you don't have any money. You don't have insurance. You can't just call your insurance company to get you a ride to your mental health care. That leads to many people who end up stopping using their medication because they either can't afford it or can't get to their appointments to get them. Again, that revolving door continues to happen because being unhoused, being unfunded, how do you maintain any level of care? And because of that, you're constantly going through the same symptoms and they worsen. So just a mild depression can turn from a mild to very severe depression very easily. It can become cyclical to the point where you don't have up days anymore. Very common. Now, I mentioned how the ER takes the burden of caring for patients waiting for placement, which is very true. I'll give you an extreme example here. Now, this example is admittedly going to get a little graphic to emphasize the point of the problem and to illustrate what it typically looks like when we have someone who has to go. Now, there is some nuance to the fact that there are people who go in voluntarily, meaning they want to go get help, and people who don't want to go, who have to go involuntary. Those distinctions are very important, and we have to discuss that. So I'm going to put a timestamp below. So trigger warning, this is going to be discussing suicide, and it's going to be... I'm going to try and keep it as ungraphic as possible, but I need to emphasize like how badly the system fucked up so that you can understand what it is that we face on a regular basis as mental health care practitioners in the field. Now, to set the stage, we had a man call, and this was something that happened about 2 years ago, sometime in October, where a man came into the hospital. The police brought him in. They placed him under an apprehension without a warrant, basically an APOW, or an emergency detention order, which is basically, hey, you can't leave the hospital for 72 hours because you are at risk of hurting yourself or someone else. So this man had called the police on himself. He was planning on committing suicide. He had it all planned out. The only reason he reached out to the police was for them to collect his body. Now, the police just so happened to get there a little early. The man's plan was to run, and he had everything already set out. He had a rope tied to a tree, run through his car, through the window, so that when he pressed on the gas pedal, the rope would pull on his neck and kill him instantly. However, the police got there before he could enact that plan, stopped him, APOW'd him because this person is a danger to himself or others, was still reporting suicidal ideation, planned to go out and do the same thing if he got out of the hospital. The man had just lost his job. He was unfunded, so we had to go through NIPTA. But whenever we have someone who goes involuntarily, we also have to sign OPC paperwork. And OPC stands for Order of Protection, Order of Protective Custody. That has to be signed by the doctors. That has to be signed by, like, the police typically have to have some involvement. Now, in a lot of other places, because I've heard doctors talk about this, you don't need the cops to sign an EDO, an APOW, or anything like that. But in Dallas, the Dallas County Judge, for those of you who live in the DFW area, your Dallas County Judge requires that there is police involvement, or else they usually won't sign off on an order of protective custody saying this person is a danger to themselves or others and needs to be involuntarily placed into a psychiatric hospital for psychiatric care. Now, I don't like having to take people's rights away. You guys can probably understand why I would be hesitant to do that. But when someone presents a clear present danger, like the man who had called the police, we have no other resource. We have no other recourse because that man had a very specific plan. He knew what he was going to do, and he was about to enact it before the police intervened. The one time they did their job right. And I will come back to that, by the way. Now, they had him EDO'd. Okay, so I have to step back a bit. Before a judge can sign off on an OPC as well, there is one extra step that they have to take, and that's getting funding for that patient so that they can get approval to go to a psychiatric hospital. So you can imagine that created some difficulties because we have to wait for NIPTA first to give us approval, and we only have a 72-hour window to get that done. So, there we are, trying to get him funding. Trying to get him funding so that we can get him assigned to go. So while NIPTA is making the decision of, okay, we're going to go ahead and fund this client or not, we can't force this man to go anywhere. He has to stay in the hospital for 72 hours. If he were to stay that 72 hours and that hold falls, meaning that it's been too long, that means that we then have to get a new APOW, which is like pulling teeth because at that point, police really don't want to do that. One, they don't want to do the paperwork, and two, they don't want to take anyone's rights away, usually. Again, I will go back to that in a minute. But here we are, waiting on this man to get funding. And the North Texas Behavioral Authority closes the case and says, we're not going to fund him. Now, my offices have the general question of what the fuck? And NIPTA, whatever representative who decides and arbitrates these things, gave the unwise, I would say deeply unwise, opinion that, well, if he was suicidal, why did he call the police? Even though we explained this man called the police to collect his body so it wouldn't be rotting in the field wherever he was. He didn't call them because he wanted them to stop them. He just so happened to be stopped. Now, that man, I don't know what ended up happening. I do know that my offices ended up having to fight for that guy for a very long period of time to get him care. I don't know if he ever actually got it, though. Now, mind you, this wasn't a client I saw. This wasn't a person I had assessed. But I remember the hospital that told me about this being absolutely furious because it was such a lapse of judgment on the North Texas Behavioral Authority. The fact that they get to arbitrate who gets funding and who doesn't is one of the major fucking issues within Texas, within Dallas. Now, mind you, they don't have all the funding in the world, but why should that be a problem? When I have patients who come in kind of regularly, who, I mean, they got no other option, they get funded fairly easily and they go. And a lot of times, what will happen is after 3 times you come to the hospital doing this, there's a chance that if you have no insurance, we can hit you with a malingering note and say, you're not engaging in your own care, we're not going to send you anywhere. It's awful. Or if you're a known drug user and you're a known substance abuse user, we can say, well, this person's not engaging in their care. We're going to give them some chemical dependency resources and send them on their way. How they get to those chemical dependency resources is no longer on us. Now, mind you, hospitals only have so many bus passes and stuff to give you. But let's say, for the sake of argument, you live in my area, which I'm not trying to dox myself, guys. Please don't look for me. Please. I live in an area where there are no buses. There are no public transports. And the reason they do that is so that they eliminate the homeless and houseless element. They can't be here if they can't travel on their own. It's kind of a nightmare, and I hate it. And that doesn't make the area any safer or not. It just means that fewer people have access to get jobs. So you either have a privately owned vehicle, know someone who does, and can get to work, or fuck you, buddy. So, if a person who has no way of getting to that chemical dependency resource, we do it because they are not enough of a threat, or it seems like it's related more to the chemical dependency. I don't agree with that being the process. It just unfortunately tends to be the process. But going back to NIPTA being the arbitrator of all of this, then you have, if NIPTA approves it, the Dallas City judge, who gets so many of these cases and decides whether or not that person has just cause to go inpatient to a psychiatric care unit, if they need to go involuntarily. Now, in fairness to the judge, they also don't want to just willy-nilly take people's rights away, because that's what it is at the end of the day, having to take your right to go home away so that you don't harm yourself or anyone else. But again, if we have presented this, you are a clear present danger to yourself or someone else. I do want to point out that if you have an EDO or APO, my office is told you have to automatically fill out an OPC, whether or not the doctor wants to sign off or anything on that. It's on an individual case-by-case basis. If the doctor chooses, yes, this person needs to be we've done a clinical mental health exam and proven that this person is a danger to themselves or others, or too decompensated to care for themselves in any capacity, we essentially say, okay, this person needs to go. The Dallas City judge sometimes, and now this is technically a rumor, but for those of you who live in the DFW area, you need to know this. This judge will sometimes just sit on these cases, wait for the 72 hours to run out, and say, sorry, couldn't get to it. Let it lapse, and then we have no other recourse but to let that person go. Sometimes that works out, because in that time, waiting for funding and waiting for placement and waiting for a judge to sign off on it in those 3 days, you might start feeling less suicidal and just fucking bored being in a fucking hospital where there's nothing going on and feeling like no one's listening and you're being constantly ignored. Because, unfortunately, in the ER, there are hundreds of other patients who come in for various things, and what ends up happening is you're kind of left to your own devices. Of course, they come and check on you and everything, but at the same time, it doesn't feel like one-on-one care. So you're sitting there, and after a while, you just start saying, you know what? I'll tell you guys anything you want if I can just go home. If I can just get away from this, because this is making my mental health worse right now. Yeah. What else are they going to do? So we have a myriad of interconnected problems going on with just trying to get someone placement to a crisis center. And the people who get to make the choice of who gets to go and who doesn't, again, it feels so arbitrary sometimes. Now, mind you, there are plenty of counties where they have some form of this. I was in Colin County. This happened this week, where I had an individual who presented to the ER looking to get placement to a psychiatric unit because they were having psychosis. Pretty severe psychosis. They were decompensated, meaning that they weren't able to tell me like who they were, how to get home, any of those things that potentially make them a danger to themselves, because when you're in the midst of a major psychotic episode, and we'll talk about that in a different episode. We'll talk about like specifically schizophrenia and the common misunderstandings of schizophrenia. But in the midst of psychosis, trying to get care, was told by Colin County MHMR, which is their community mental health, that, yeah, but we need to get you medically cleared before we can get you to a psych hospital. So the person presented the person presented to a hospital not too far from where they lived and told them the story. The hospital medically cleared them. They called Colin County MHMR, and MHMR told them, we're sorry. We need to do another assessment to see if this person still needs to go inpatient. They were assessed. They were told they were needing medical clearance. Why are we still holding this person if that's all they needed? Well, we have to go ahead and do another assessment to determine that now that they're in a different location. Nothing has changed with this person, by the way, other than they're at the hospital. So the nurses ask, okay, when are you going to send an assessor out? We don't know. Hours later, they call my company. My company is a third party that goes out, for those of you who don't remember. We go out to do assessments to determine level of care for people. And the nurses, everyone was just baffled by the absolute gall of MHMR to just not send this person directly to a psych hospital when they were asking voluntarily to go in. So What the nurse told me is we called your company because we know if we sit here and wait for Colin County MHMR, they may not get to this patient. So I do my assessment, call MHMR myself and tell them, hey, this person needs placement. Now, sometimes what will happen is they'll send someone else to do a third assessment, or in some cases, a second to third assessment from that county to basically tell that person what we have already said. Yes, you need a higher level of care. You need to go to a psychiatric unit. I'm glad that person had to go through that twice. I'm sure that is wonderful customer service. I'm sure that that patient is feeling fucking great about that. And they have to sit there for hours at a time waiting for placement while they're still dealing with the severe psychotic episode. That person did eventually get placed, but the fact that they had to go through so much because they were not funded, because they didn't have resources, and how could they? They have been slowly slipping into their psychosis for a long time, for over a year. There are people with schizophrenia who can hold down jobs, who can live normal everyday lives. Most of them can, with funding, with medication, and with support. It's completely feasible. This person had support, but no money, and no way to make money, because when you don't have the means, right, if you can't afford your medication, your psychosis gets slowly worse because of without intervention, it can get worse. Some people can go like weeks to months at a time without having an episode. But then when they're off the medications and an episode happens, it can be pretty severe. And so getting that person back on medications can also be like pulling teeth. There is a lot of stigma involved with being on medications, and we'll talk about that in a separate episode as well. How being on medications feels weird, feels different from one's reality. So of course they don't want to take the medications. So they've been off medications for about a year because one, they stopped them, and two, no money coming in. They could not hold a job. So of course they're getting worse. This is a very common occurrence. The more extreme your mental health is, the less funding that you have ability to get to. And we will talk probably in the next episode. We'll talk about disability and mental health, and how if you think getting on disability is easy, by the way, you've not done it. If you've heard stories of, oh, they got it and it was like blah, 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 super easy. No, the fuck it wasn't. That is a lie and a myth. It is a lie perpetuated by media, and it is a lie perpetuated specifically by Republicans, and I'm going to call them out here, to perpetuate the myth of the welfare queen. Most people who have disability, you're lucky if you make $750 a month to live off of. And we'll talk about how that directly affects mentally ill people and people of color, people in minority groups. But right now I want to focus on how the burden on EON to get these people to crisis locations. You've probably heard people talk about this. If you know Adam Ruins Everything, he's actually talked about this in the past in one of his episodes. I don't remember if it was on a Netflix episode or if it was on one that was on YouTube. But he talks about how ERs have long wait times specifically because there are patients like those with mental illnesses who come in who they have to hold for up to 72 hours, sometimes longer, as I've pointed out. And that means fewer rooms for people to be seen. The fundamental thing that you guys have to also understand about ERs in general, same thing with psychiatric hospitals, they're triage. They're not meant for long-term care. They want to get you in and get you out as soon as possible. Not because they hate you specifically, but because they have a constant stream of people coming in. Now, there are smaller ERs, like you've got the big ones, the big hospitals with emergency rooms, and then you've got like the small pop-up ERs that are just basically almost like urgent cares that are around the corner and stuff like that. They're all over. They look very nice. They look very clean, but they don't necessarily have the same function as a hospital. They don't have the facilities. Again, they definitely do not have. So if you go to a sure point, or if you go to, again, like an urgent care, or one of those that isn't in a big hospital, the chances of them having psychiatric care, goose egg. Not going to have it. Almost 100% guaranteed they're not going to have that because that's not what they're there for. And so I sometimes have to go out to them to do assessments for people and then try to get those people placement and go from there. Now, I want to talk very briefly, and I know it seems like I'm jumping all over the place. Again, I thank you very much for your patience with me. But let's talk about the police's role in mental health care. Now, the police don't get a whole... Well, the police get a lot of training in a short amount of time, and it's not enough. We give them all sorts of military-grade equipment. Fucking some places give them tanks. Because, of course, we need that. But then we rely on the police to do too many things at once. We ask them, and this is me being as nice as possible. If you guys didn't kind of recognize, I'm very much an ACAB head. All cops are bastards. I have met really great cops. I've met really great people behind the badge. But at the end of the day, every cop is a bit of a bastard. To the degree and level of that bastardness, it's differing, it's varying, but they also engage in a system that they're not usually there to protect people, they're there to protect private property. Again, I've met a lot of great cops who fundamentally do care. But then they're the cops who shouldn't be doing the job. Period. Meaning they don't care, they just want to get there, drop off the person, not do any paperwork, and move on. Being as kind as possible to the police, they are overwhelmed by the number of things they're tasked to do that should be offset to other resources, other places. A cop shouldn't have to be the person doing a mental health exam to determine if somebody needs, like, mental health care. What I mean to say is, in the past few years, there has been a push to have more mental health practitioners in the field trying to assess crisis situations so that we can get them treatment. The problem with it is there are a lot of cases and only a handful of assessors. And this is true even at my job. Put it to you this way and put it in perspective. Typical night between 10 p.m. and 6 a.m., there are 3 of us for the entire Dallas area. And if one area gets slammed with a lot of patients who need mental health care, that means up to 2 of us need to run around and go to these places as quickly as we can. Some nights there's no calls, and some nights it is just back to back to back to back to back with no rest. Those nights are concerning, but lucrative, unfortunately. Now, the police themselves don't have enough training because, again, they have to be out there doing their jobs. You know, they have to be out there patrolling, they have to do this, that, and the other. Um, so they don't have the luxury of being trained on how to assess these people, how to care for these people. Um, and there are people who, when they get arrested, they start claiming having mental health issues just so they don't have to go to jail. I had something similar like that happen recently with a man who decided he was being arrested because he had a warrant and decided to act a certain way. And then when the cops left, was perfectly reasonable, fine, and mostly polite. Kind of a common thing, but that isn't to say that it is a loophole that people constantly use. It's not. It really isn't. But cops have a tendency to escalate situations for people. If you're in a mental health crisis, you don't want to talk to a cop. You see a cop, and if you're a person of color or if you're a person of a different socioeconomic group, you're going to see a cop and think, "Ah, shit, I'm fucked." That's just how it is. I mean, especially if you're a if you're a black patient, seeing the cops can be very agitating because some of them who join forces are the same who burn crosses. We know what I mean. There's so much that, like, again, hesitation to be confronted by the police. And you've heard plenty of stories where a mentally ill person gets mowed down by cops because they're mentally ill. There is a specific method of suicide, trigger warning, by the way, called suicide by cop, where you agitate the police into shooting you. It is a very effective method, and people have attempted it and survived, surprisingly enough. So this is a thing that makes all cops bastards. If there are cops who can de-escalate situations, that means that there is no reason that a person should be shot while having a mental health crisis. Still happens. And this is Dallas. I'm not saying it doesn't happen all the time. Again, there's a lot of competency and there's a lot of incompetency. Um, Case in point, here in where I live, the police picked up a woman who was naked and having a psychotic episode while she was holding a knife and kind of threatening people. They brought her to a hospital, but they did not place an APOW on her. They did not place an emergency detention order on her for any reason. And when we asked the cops to come back and place one on her, they refused. They didn't really give a reason. They said, well, we suspect that she may be on drugs. She wasn't. But it can be very difficult to get an emergency detention order after they've already been sent to a hospital. Things like that are some of the biggest major issues. So you've got lack of funding. You've got arbitration by NIPTA. You've got arbitration by police who choose whether or not you should be APOW'd and whether or not they should be bothered to fill out a single page paper and if they can fill it out correctly. Because a lot of these cops, they will fill out with things that, because you're supposed to put down what you see, what makes this person a threat to themselves or others, and what makes them, like, if they're decompensated, if they can't answer basic questions and stuff like that, they are put at risk. And if you see them, observe them doing something that is harmful to themselves or others, that's what needs to be in the report. It's a one page. It's one page, very straightforward, and they fuck it up a lot. They fuck it up a lot, no matter how many times we've had to explain this is what needs to be. You can read. The reading comprehension there shouldn't be a problem. And yet, you'll see people put in things that are not enough to prove that a person is a danger to themselves and others. And then for the second section where, what did you observe? See above. That is not enough for us or the judge to go off of. And since the judge demands that you, the police, write this up for us to be, because in other counties, in other states, a doctor is all you need to say, hey, this is what they've observed, this is what they've seen, this is what makes this person a danger to themselves and others. Sure, we'll sign off and we'll go ahead and do that. But needing the police to do this and knowing that the police don't do it well leaves room for people to get hurt. And that is an extremely frustrating situation. Now, all of this has thus far been about crisis care. This has been, you need inpatient care. The next episode of this, we're going to be talking about MHMR. We're going to be talking about the different levels of care that are available to people. And we're going to be talking about how those things fail. So, kind of giving you a precursor, you've got partial hospitalization, which is we let you leave the hospital, you go out and you follow up with a psychiatric hospital on your own, and you go in for a few hours at a time and you come out, come in for a few hours at a time, come out, so that they can monitor your behaviors, your medications, all of that. Only available if you're funded. We've been straight up told it's only available if you're funded. If you're not funded, you go inpatient or you go outpatient. That's it. Then the next level of care down is intensive outpatient. Now, some people who are not funded do get into intensive outpatient programs, which is basically we see you more frequently, we're more involved, we're trying to get you either transitional living, we're trying to get you into programs that will benefit you, etc. But once again, those teams like the ACT team and stuff like that, where it's intensive outpatient, there are only so many people in the DFW area, and this is just using DFW as an example. This is very common throughout most major metroplexes. You have a small number of teams working on this and a large number of people in need, and so you could be placed on a wait list. And if you're placed on a wait list, it might be a while before you actually go through, and in that time, things could get worse and more intense. The final thing is outpatient care, which we'll be talking about more in the next episode. And we'll start off with outpatient care, because most unfunded people, like I said, are told outpatient or inpatient, and inpatient is very limited. And you can see where a lot of the frustrations are in the system, and those systemic problems that are failures. Failures to the community, failures to you, the individual, and failures to everyone around us. Now, unfortunately, one thing that I realized that I have not been able to touch on is the role of the VA in stuff like this. Because veterans, if you don't know the statistics on veterans, there is a large number of people who need mental health care who are veterans. And they have a little bit of an easier time. I say a little bit of an easier time getting access to care, but even then, look at how much Doge has been trying to pull funding from the VA, from veterans. Because once the military's used you, they don't want to live up to the promises that they had you sign up for. So you get constantly people who need to get their health care and are told, well, that medication's no longer covered, or that's not covered, your counseling's not covered, etc. And so the VA is its own pathetic monster. And you'll hear veterans talk about this all the time. The failure of the Veterans Association to give them the help that they need. Because there's still this mentality of, get over it, kid. It was however many years ago. Get over it, kid. There are plenty of people who have more experience with the VA who can talk to you about this, but I want to talk about for veterans, Veterans in crisis, if you have funding through the VA, we can get you services. If you have no funding or were dishonorably discharged, but you served in the Army, if you served in the military to any capacity, no matter how you were discharged, in Texas, we have a program where, and this is a brand new program, it's like 3-4 years old now, where we work with the Veterans Association to say, okay, this person is unhoused, this person's unfunded, whatever the case may be. As long as you served in the military, we will do what we can to try and get you to inpatient care. So if you are a veteran and you're feeling suicidal, you can come to a hospital, get assessed, and then we can go through the VA, try to get you placement. I can't remember the exact. Unfortunately, I can't remember the exact bill that created this. It's the one damn good thing Texas has done for mental health care in a long time. That Greg Abbott and Ted Cruz haven't just decidedly tried to make worse. But the idea is that doesn't matter your status as a veteran, doesn't matter your status of your discharge. If you were discharged, if you served, we will try to help you. Now, one thing I also didn't talk about is I'm going to use Tarrant County. It is right next to Dallas County, and it's huge. Tarrant County has no MHMR. It has no community mental health. It has no resource put into, hey, if you have no funding, we have to wait for what's called a charity bed, meaning a bed has to open up at a psych hospital and they have to be willing to just take you. And then they have to foot the bill, basically. Or they send you a bill. So if you are in the Tarrant County area, you have no funding, you live in that area, and you're having a mental health crisis, getting you placement is going to be difficult. The reason I want you guys to know about this, especially for those living in those areas, because you're not the only county with this problem. A lot of people are going to need to look up their counties to determine what is their resources in case your insurance lapse, in case you lose your job, anything like that. What your resources are. Look up your local MHMR. Put your zip code in Google, and then just whatever your zip code is, mental health care. Just put MHMR, and it will show you what your community resources are. Now, for inpatient care, waiting for a charity bed, it sucks. It's terrible. And I think the more people who understand how much of a problem that is, the more they can make people create resources and put funding towards it. Because unless they see that there is a vast number of people calling for a need and like calling for us to do that, they're not going to do anything about it. They're just going to stick to what it is, which is, sorry, pal, you're fucked. What do you want us to do about it? Dallas can't get away with that because we're too big. But Tarrant County encapsulates a lot of really large, vast areas. And it is a nightmare. We're talking, so if you're in Dallas, if you're in the Dallas area, we're talking from like Grapevine to I think Mansfield and Midlothian. That area, all of that, Tarrant County. Arlington, big parts of Arlington are mostly in Tarrant County. So there's a whole strip that's just Tarrant County where you don't have any coverage, and if you have a mental health crisis, sorry. And then we wonder why mental health is... Let's talk about this really quick, guys. I've been avoiding this because I just thought about it. We have a lot of violence and gun violence in America. It's Texas. That's kind of par of the course for a lot of things. We just had a school shooting 2 or 3 days ago that barely made the news. We claim that it is a mental health crisis, and then we do not fund mental health. We have the police do everything. We put more funding. When we talk about defunding the police, we mean demilitarizing the police and putting the same resources that we put into the police into mental health care. Putting it into having more assessors, having more access, giving people options to de-escalate and get them the help that they need. But that's complicated. And our government doesn't want to do that. Now, this is not just a Texas problem, and I keep telling you guys this. It's not just a Texas problem. This is a problem throughout the United States. Doesn't matter if you're in New York, doesn't matter if you're in LA. We put more funding to the police than we do to any sort of MHMR. Now, I've been using the word MHMR a lot. If you have questions about that, I will explain that in the next episode. But it's a very terrible acronym, like I said in my introduction. It stands for mental health, mental retardation. Initially, what MHMR was for people who have really bad mental health issues and needed extra care. So people with intellectual disabilities, for example, which was prior to the DSM-5 referred to as mental health retardation at the time. I am not using that in a derogatory way. This was the language of the time. We have moved on from that. However, MHMR has not. Unfortunately, it is still referred to as MHMR. Most of us in the field just don't call it what it is. We don't use the full, we just use the acronym. That is going to be a separate episode, and at the top of the episode, I will bring that up. But when you don't have funding for community mental health in any capacity, you're going to have mental health crises all over. And I've seen places like Hunt County, I've seen places like places that are more remote in Ellis County, all over, where they have some form of mental health that is meant to support the community. But if you live in far off places, like this is just the DFW area, right? So if you live in San Antonio, if you live in Corpus Christi, there are mental health resources for you. But if you live in a small, almost no-name town, their access to care is extraordinarily limited. And that is a problem too. We don't know how to expand that. We don't know how to expand to those areas, and that leads to a lot of gaps in people's care. That leads to a lot of gaps and problems for people in crisis who have no other option but to go to a hospital. And if they're lucky, that hospital may have psychiatric resources. But as I said, most of them do not. And I know in certain places, like in New York and again, LA, they usually do have some psychiatric ward. They have some psychiatric unit. But even those are becoming a little rarer. I can't speak to those situations. I would love to hear somebody. I'd love to interview somebody on this show. I'd love to interview someone about this and get some perspectives from outside of Texas and see what the failings are in various other cities throughout the US, because it's beneficial to you, my audience, and to everyone out there who's struggling with mental health problems and dealing with these frustrations. And the more knowledgeable we are about it, the more we can all voice, hey, we need to do something different about it. Again, we don't have to shake things up and get violent, but we can get our voices heard and get our opinions out there. Whether they'll listen, well, let's just say more people voicing it leads to more people being forced to listen to it. But What I'm seeing is that more and more healthcare and mental health care being pushed to the private sector is leading to really bad outcomes. It's been leading to bad outcomes for the longest time. And we'll be discussing that more as we get to um, mental health problems in outpatient care. Like I said, that will likely be in the next episode. And then from there, we'll be talking about um, talking about the different impacts of mental health issues, comorbidities, stuff like that. I've got a whole list of things. So I want to thank you all for being here for this episode, listening to me. Again, I know I can get all over the place, and I know it's not visually very stimulating just having a guy talk at you. Um, I'm I'd love to get your guys' feedback on this episode. I'd love to hear back on what you guys think about how helpful this is, things that I can improve. Um, I know that if I really wanted to do more research and had the time to do the research, I could put all kinds of facts and figures and statistics up here, but this is for the everyday person. You don't need this just the statistics. But I will give you one statistic. At my job, we have all of the people that we send to psych hospitals who are unfunded. Of the 100% of the people that we go, that we try to get placement, only 30% get the coverage and get to go inpatient for any number of reasons. So there are plenty of people, that is 70% of people who are unfunded, who require higher level of care, just don't get it for some arbitrary reason. That's a major issue. It's been a major issue for a long time. So I will close out with the more knowledge we have, like I said, the more people are aware of this issue and how it affects them directly, how it affects the community directly, and how it affects, because those things ripple out, right? Those things always ripple out. The more that we know, the more we can change the system. One of the last things that we'll talk about in this series is potential ways to, I guess, either fix the system or more reasonably, things that can be done to not circumvent the system, but to call for mass change. And I think maybe at the end of the day, as a mental health practitioner, that's what I want from this series, is for you guys to feel empowered listening to these frustrations from this end of things, knowing that you're not the only one frustrated and annoyed with the system, but hopefully get to a point where you guys can do something about it with us, with the mental health practitioners. And if you're a mental health practitioner who has seen this and said, yeah, I know about all of this, I'd like your feedback too. The more knowledge we have, the more we know, the better we can do something about it. But this is a long, long piece, and I very much appreciate you staying here to listen. I appreciate the fact that you gave this like the time that it needs, and I hope that it's cathartic knowing that again, you're not you're not the problem. A lot of the time, you're just suffering. The problem is the system not getting you what you need. And we will talk about that more in the outpatient care part. In the meantime, I want to thank you all so very much for watching. Um, be sure to like, favorite, share, subscribe. Please share this. I want as many people as possible to be turned on to this series so that the discussion of mental health, the discussion of the systemic failures of mental health can be more widespread. I want more people talking about this because right now in this political climate of things going terribly, it's not about being a downer. It's about these are all important issues and we need a call for reform. And the more people, the more eyes on it, the more voices in it, the more people talking about their own experiences and the systems that have failed them, the more real it gets, and the more we can do something about it. So I will see you in the next episode, and I'm sure it will be very lengthy as well, because there are a number of topics related to outpatient care that we're going to be hitting on. I touched very briefly on disability here. I'm going to be going in more depth, probably in that episode, because it is so closely tied to the care that you get. In the meantime, thank you all again. See you in the next one, and as always, sweet dreams and pleasant nightmares.